So now we're going to cover BIMS and PHQ9 section of your charting. This template in assessment is required on all new patients as well as these yellow patients. You should have watched the other videos first, but if you have not, the yellow patient is a patient that you've seen before but has left and come back into the facility. They are now billed as a new patient even though you have seen them before, and a new PHQ9 will be required on that patient. So let's get into how we chart for PHQ 2 to 9 in the BIMS. So we click on our patient, and again, the view clinical note, and our additional. So we go down all the way to the bottom, and again, we talked before about these are the three templates that we use 99% of the time in the facility, but for this case we're going to go on the BIMS and PHQ 2 to 9. And so this section right here is sort of just a little bit of to keep notes while you're charting on the patient. There is an application you can put on your phone. It works. I'm not sure if it works in Androids, but I know for iPhones and iPads you can use it. And when I'm charting in the patient room, it helps me keep track of, while I'm charting on the patient, to make small notes and address issues with the patient with just by charting these top items, and then I can do the rest of the stuff later. So where the charting really starts is conduct BIMS. And the reason why this is already marked yes and yes, do not change these, is that we are required to do a BIMS and a PHQ9 on every new patient. So the obvious answer is yes. So instead of having to click these every single time, I automatically put them in yes. And if you notice that the BIMS, this format of these is a little bit different than if you had done a paper BIMS in the past or download a BIMS assessment on the internet. And the reason why is most of our facilities use point-click care, and there's a very specific format and questions that are answered. So that way, if our staff has to transcribe your answers into the EMR for point-click care, it is easier for them to do so. So again, the BIMS, if you've seen the BIMS or done a BIMS before, it's basically the repetition of 3 words. If they get all 3 words, bed, blue, sock, they get a 3. If they were only able to get blue and sock, there you go, it's a 2. And the number here correlates with that's what you use to add up for the total score. A perfect BIMS is a 15. So the correct year, the correct month, the correct day of the week, and now you go back to the original bed, blue, sock that you discussed in the past. If they're able to recall all 3 of those, again, you click on those. There is no automatic scoring for this. So once you're done with the charting, you do have to go back in and add up your scores, and you can put that up towards the top. Say the patient scored a 14, that's their BIM score. If you had them at alert and oriented times 4, you can put that back in there when you're completed charting. So what's a little bit different from what you probably would not see online is the signs and symptoms of delirium. So this is required by the facility when we do a BIMS and PHQ9. Again, what's important here is to chart to the best of your ability. And again, if there's acute mental status changes, it's a pretty simple one here. No. Inattention, disorganized thinking, altered level of consciousness. This one's pretty straightforward. Just answer it as you see fit. What I want you to pay special attention to is in the care plans. Under dementia, we cannot give dementia diagnoses. So if the patient does not carry a dementia diagnosis, but their A&O status, if the facility did a slums, I mean, you can tell when the patients are demented or have dementia in some case. Again, unless they have the diagnoses, never put yes. They have to have the diagnoses of dementia in order for them to say yes, even if you know without a doubt they have it. If there is not already a diagnosis of dementia, use suspected but undiagnosed. It will create a ton of problems, and we just be careful with this dementia one. Same with the rest of these. They aren't nearly as important. If you feel like there's a cognitive deficit, you can put yes or no. Dementia is really the one that you have to be careful with. And when we get to the PHQ 2 to 9, so this one actually should be always yes. And then as you notice, the A1 and A2 are the same. You can see that, the same. So the A1 is literally just, does it exist or not? Yes, no, or no response. And then the second part of the question is the scoring of it. If it's never 2 to 6 days, so this will be at the actual component that you use to tabulate your PHQ 2 to 9 score. So it's always the second part is your scoring. So the important part I wanted to cover in the PHQ 2 to 9 is on the mood interview. The most important part of this assessment is A1, A2, B1, B2. And why is that? So the rules changed for CMS a while back, and they basically stated that if, for whatever reason, either one of these is a no, A1 or B1 is a no, even one of them is a no, and then even if it's a yes, but it's a 1, and this is a yes and a 2, you are not supposed to be able to finish the rest of the assessment. So the patient could have difficulty sleeping, they could have little energy, they could be overeating, they could feel bad about themselves, they could not be concentrating, they can speak in slowly, and they could think they're better off dead. But the PHQ 2 to 9 will show not able to complete and not basically qualify for depression. So what my recommendation is, and this is up to you, you're the provider, you make the decision, but if you want to complete the interview, which we do this interview on everyone, it's really important, in my opinion, to get through, because you want to basically, to me, I really want to know the answer to this question, thoughts being better off dead. Then you must, in order to get past this, you have to go yes and either a score of 2 or 3, and yes, a score of 2 or 3. And this allows you to complete the rest of the evaluation. And I can tell you that every single one of my patients scores yes and either 2 or 3, yes or 2 or 3 on this first section. So I am able to complete the rest of the assessment. So every facility is a little bit different on patients, that the very few patients that may be aphasic, they're maybe minutes from rolling hospice, the myriad of different reasons that you are not able to complete the interview. Every facility handles those situations very differently. Reach out to me and we can specifically go over your facility on those unique circumstances. Most of the facilities that you'll be in, they want you to complete the PHQ 2 to 9 as best you can, regardless of the situation. But again, when you end up in a situation where you're unable, or you feel like you're having a really difficult time completing the PHQ 2 to 9 because of the patient's mental status or lack thereof, give me a call and we can walk through it together. So something a little bit more about the PHQ 2 to 9 in the BIMS. The PHQ 2 to 9 to BIMS is extremely important to the facilities. It's also extremely important to us. So what's most important, and I've created a little bit of a kind of a template here, or sort of like best rules moving forward with BIMS, and that is, it's not necessarily important, because to me, I can basically accomplish a BIMS and a PHQ 9 by having a conversation. When you first start, yes, go down the list, do the best you can. But what I find is that you do not get an engaged patient when you just go down the list of questions question 1, question 2, question 3, and you make them answer like a robot, you probably won't get accurate answers. And so when I have a conversation with the patient, what is important? The category. And what I find is that an A&O status of 4 will typically mean a BIMS score of 13 to 15, because a score of 12 literally means some mild cognitive impairment. So a mild cognitive impairment, a patient who has an A&O status of 3, person, place, time, self, then their BIMS should reflect that, a 12 to 10 roughly, but it should be lower than 12. It should be 12 or lower. A&O 1 and 2, again, you're looking at less than 10. A&O 1, you're looking at less than 8. Actually, probably more like less than 4. So, but again, you're the provider, you have to make these decisions. But when I'm in the patient's room and I'm interviewing them and I'm assessing them and I'm looking at the room, I'm listening to their answers. So some great examples here. You do not do the patient any favors by helping him through this assessment by, if they have to guess 3 times to get the answer right. I use their answer, the first answer they give, and I do not assist with at all. And the reason why is the patient doesn't get extra support or resources. The facility doesn't get any extra support if we do not do these assessments aggressively. And so for an example, the patient, for the most part, seems pretty A&O times 4, but they can't tell you, hey, what's the name of the facility that you are? And they'll tell you, well, I'm at the hospital. Well, which hospital? I don't know, maybe, Banner. Well, they're not at Banner. They're in a skilled nursing facility, or they're in a long-term care facility, and they're there for skilled nursing services. If you can't tell me where you are, that you automatically should be an A&O times 3. And which means your BIM score should not be higher than 12. So what we're seeing a lot of is a patient that really shouldn't be assessed as an A&O times 4, and really shouldn't be assessed with a BIM score of 13 through 15. That we need to be accurate with these, and we need to be straightforward with these exams. So please keep that in mind and take a peek at this video, look through these categories, because that's what's most important. And again, when you're in the patient's room and you're assessing them, you should know their BIM score you should be able to get at least the category of BIMS, which is a 13 to 15, a 12 to 10, or a less than 10. You should be able to get those categories just by having a conversation with them. Other example that I'd like to use is they can typically answer their basic alert and oriented questions correctly. However, they cannot reliably answer basic history recall questions. And that should typically, in my opinion, result in a score of 12 or less, which would suggest that they're not really alert and oriented times 4. So patients get very savvy on answering questions, particularly if they're trying to hide a little bit of dementia, if they're anxious about maybe they had some hospital-based delirium. They can trick you. I've been tricked many, many times. I'm sure all of you have as well. That it's not that big a deal, but take the entire assessment, take the entire patient into account when you're asking orientation questions. And you ask orientation questions, you initially have them as a 4, you initially have them at a 14 in the BIMS, but then as you ask more questions, you realize very quickly that this patient is diminished. Their score should be accurate to that diminishing findings that you're having, and make that adjustment, make that score reflective of what they're really at, 12 to 10 with an A&O times 3, if you're finding them struggle with some pretty basic stuff. The second component is the PHQ2 to 9. We already covered a lot of the charting that goes along with that, how to chart it, but some also tidbits of information on the PHQ2 to 9 scoring, which we also see a lot of patients that they're on 1, 2, 3, maybe even 4 psychotropics. and they're not getting a BIMS, or I'm sorry, a PHQ-9 score of 10 or higher. And I find that a little bit frustrating, where the example I like to give is hypertension. If you're taking lisinopril and metoprolol for blood pressure, and your blood pressure gets measured at 115/75, do you remove the diagnoses of hypertension? No, you don't. They still have hypertension. They are just, it's being controlled with medication. So typically what we see on accurate charting is if the patient's on psychotropics, if they're on sleep aids, if they have a history of anxiety, depression, psychosis, insomnia, dementia, or suspected dementia, more often than not, we should see a score of 10 or higher on the PHQ-9 assessment. So if you have any questions on any of this stuff, please reach out, and I'm happy to answer them for you. Thank you for your time.